Thanks, Ralph, and good morning, everybody. I was given the task of trying to show you guys where we are at with drug spatial localization with MR. And like every good lazy student, I thought I'd ask AI to help me. So I said, AI, generate me a figure of where we're at with drug localization with MRI. And this was the result. So the one on the left, I think the only thing it got right was the dead looking eyes on the researcher there as we try and do this. What we can see on the screen is what looks like a diffusion map. The tensors outside the brain. I'm sure a lot of us in the room, when we've looked at our data, often see these spurious results everywhere. But more worryingly is that AI thought we have a brain in our tongue on that left image. What I did like was the image on the right, which is really how are we monitoring the drugs? Are we doing it directly by using our MR to look where that drug is, or indirectly in terms of what is the effect of that drug on our system, on our physiology? And I'll talk a lot about how and the importance of preclinical imaging in drug localization techniques and the development of them. And again, clearly AI knows nothing about MRI. Look at all the metal it has around the scanner there. Hopefully we don't have that in our scanners. So in terms of how do we use MR, we come back to kind of a base level of MR. There's only a few parameters we can affect, right? And most of those involve the MR relaxation properties, T2 and T1. We can vary the flip angle to vary the contrast. But in short, what we want is an agent or a drug that will affect those relaxation properties, and then we can see a difference in contrast where that drug is, right? It's that simple. No different to how we spatially recognize whether something's gray matter or white matter. And we've already seen through some of the other talks, one way of doing that is with a spion or a superparamagnetic ion oxide. And in short, you can do it with a paramagnetic or a diamagnetic agent. You just need to alter the magnetic field. Very basic kind of picture here of how those materials alter them. And those who understand fMRI will know that we have paramagnetic deoxyhemoglobin in our body that acts as a contrast agent inherently. But ultimately, we want to affect the magnetic field and drive those relaxation changes so we can monitor where these things are. And again, those spions or those superparamagnetic ion oxide nanoparticles are probably the most prominent example of that. So these are tiny, tiny little ion particles. And the advantage is you can bind stuff onto them, you can make them biocompatible. And there's tons and tons of research out there and a few reviews there on the screen if you want to follow that up. They have a distribution of size. Obviously, they're not all the same size, so we have to take that into account in terms of where they're going to end up, and we don't often do that. You just accept that they're all the same and they're all doing the same job. But we can also model their field perturbations and work out the extent of how far away from that particle will our effect be seen. And I don't often see that much across the literature in terms of that kind of thinking of the science. How are we affecting it? Are we exactly measuring where that particle in that drug is, or are we measuring the effect of it on a larger space? Now, obviously, we're just measuring a voxel, and we have to account for that, and that's a problem that stems across many fMRI or MRI regimes. But we can model the field inside and outside of those particles, and whether that particle is a vesicle or a solid core particle as well. And then you can go to a macro scale and work out what would it be in a cylindrical vessel, how would it affect things as we move away from that vessel. So again, if you want to know more, there's a few papers there that I can recommend that you read. Again, the advantage of these nanoparticles is that you can functionalize them. And in short, what that means is we can bind on a drug or a radio tracer and do multimodal imaging. And so, yeah, you can think about maybe putting a CT agent on so you can do both CT and MR and then combine that information. A lot of my career has been made through combining different imaging modalities, and its power is immense, right? You get that multiple shot of the same thing, and it gives you an idea of where it is. And again, if you don't want a solid core, solid magnetic core nanoparticle, you can encapsulate these things in liposomes, hydrophilic, hydrophobic particles that will form this kind of sphere that you can trap a drug within, and then it will transport to a location and open out, releasing the drug. And you can see where it is because you've got those iron oxide nanoparticles floating along either inside your liposome or actually in the membrane itself. Um, Obviously, we can functionalize them with drugs, chemotherapy drugs, which then means once it's actively targeted to a site, it will get into those cells and release it. If it's carrying the iron oxide as well, then chances are the iron oxide will remain. You'll wait a long time for the rest to wash out of the bloodstream, and then you'll see this decrease in signal because of the iron oxide and make the assumption that that is then where your drug also is. And there's many numerous examples of this being done throughout the literature. So again, this is a mouse model. I am a preclinical scientist. So there's lots of mice and rats in this talk. But we can see here a pre-injection, a nice tumor labeled T there. And then 6 hours post-injection, you start to see this black area appear where the tumor is probably necrotic and that iron oxide is leaking out into the tumor tissue. And then you wait 24 hours post-injection on the assumption that it's washed out of the bloodstream, and therefore what remains is where the agent got to, which is good. And then if you co-inject a drug, you could assume that it was in the same place or if it was bound to those particles. There is a problem with that approach. And that is that usually about 2% of the agent actually reaches the target. So you're overdosing to make sure that your drug gets to the area of interest. Most of the things end up in the spleen, and ignore the text, but concentrate on the picture. We've got a lot in the blood vessels still, but we see it in the spleen and liver as it's taken out by the immune system. And if you inject free spions on the left, they generally wash out fairly quickly. So this is just a brain image that I last did on a Bruker scanner. And free ferrocarbitran here washes out after about 30 minutes. We're almost back at baseline, definitely by an hour. It's not potentially great if you want the drug to continue around your system. So a lot of work is done to maintain that level of agent and make it more biocompatible so it will circulate for longer and therefore give you a higher chance of reaching the target tissue. And one way to do that is this Trojan horse approach, where you put it inside, or you put your agent and your drug inside another cell that is biocompatible already, and therefore you will increase its circulation time and hopefully how long it then has to get to the target and influence the physiology therein. I've been working with a group in Italy where we can do this in red blood cells. So we open up the pores on a red blood cell, we soak them in iron. The iron can get into your red blood cell along with other agents, and then you can reseal it, and then you have a spion labeled red blood cell which will then circulate around the body. The advantage being that when that cell is broken down, the iron will be dissipated its normal way and have less effect on your physiology compared to injecting the agent in its raw form. And again, the kind of preclinical work shows in the top left here that those loaded red blood cells have a much longer time in circulation around the body. We can see them in electron microscopy images here, the iron inside those cells. So it's all rather cool and exciting. We've also done it in white blood cells. So you can take white blood cells from a patient. You can put anti-oncolytic viruses within that white blood cell. You can also put in your iron oxides, and then you have both something that is theragnostic. We can see where it is, and we know it's going to treat it when it gets there. And you can stick these things in T cells, dendritic cells, stem cells, and you can track them with your MR that way. But interestingly, in terms of theranostics, what you can also do is if you've got iron and you've got a magnet, you can attract it, which means you can target it. So this was research done at UCL back in 2010. Very, very simply, a bifurcating vessel on the right there, stick a magnet one side, flow spion labeled cells through it, and the cells will be attracted to the side of the bifurcation that has the magnet on it. You can replicate that in an MR. An MR is a giant magnet. Increase the field on one side, and you can start to direct those cells as well. So we replicated this on our Bruker system. We created an in vitro flow chamber, flowed these labeled cells over tumor spheroids, and then used the gradient field of a scanner just by simply pulsing it on and off very, very quickly in a particular direction. You could then decide whether you wanted to pull the cells away from the tumor spheroids, push them towards the tumor spheroids with a minus Y, or kind of to a corner of the tumor spheroid phantom. And so that was the very basic idea. We flow these cells over that are labeled and try and attract them into the tumor spheroids. Without the targeting gradient, we see hardly any change in our T2 weighted flash scan. With the targeting gradient, we do see that massive change. So again, that idea of theragnostics, we can diagnose, but we can also increase the therapeutic efficacy by using our MR to actually direct these cells now. And you can confirm that with some fancy flow cytometry, and we see this increase from about 6 to 5% to about 30% of our cells will make it into the tumor site. We tried to publish that, and people turn around and say, well, this is great, but you need to prove that you can cure cancer. So, okay, we have to go back into the lab and actually do this in vivo. We did that. So this is a mouse model, prostate cancer, back end of the mouse, very, very crude model. Try and pull these cells as much as we can to the back end of that mouse with a minus Y gradient and minus Z gradient. And when we did that, we saw again in our post-histology and flow cytometry that increase from 4% of the cells if we had no targeting to 44% of the cells if we use that same agent to both look at where it is and to help us target that drug to the actual location. This is kind of what happens, and the nice shot is that mouse on the right there. That's the one that had both the tumor and anti-oncolytic virus within the white blood cells and the iron within the white blood cells and was targeted. And you can see it had the smallest tumor without any of the anti-oncolytic virus. The mice had to be killed at day 14 because the tumors got too big. In terms of the MRs, it's great. We can increase the therapeutic efficacy of this technique without the MRT, with the MRT, but we just see little black dots, but we see little black dots everywhere, right? Just like our AI found diffusion tensors and tracks outside the brain. You're looking for black dots on a very noisy black and white image. It's not so easy. And if you actually look at the relaxation rate on the right here, pre-MRT, obviously, it's got a normal relaxation rate. You inject the iron, relaxation rate increases, but then I increase the amount of iron reaching my tumor with the targeting, and the decrease is only slightly bigger. And again, am I really recording what's there, or what is it still remaining in the bloodstream? Because I've made these things more biocompatible. They're in a cell. How can I be sure where they are? And that's where potentially we should step away from 1H and start to think about X nuclei. We can again label these things with fluorine, these liposomes or these cells, and then the only signal you will get is from your fluorine. You'll have less confounds in terms of proton, but again, doesn't really change if it's still in the bloodstream. And so finally, in the last minute, we can look to hyperpolarization. Hyperpolarization takes our energy states, which are generally almost equally populated in thermal MR, and forces those spins from that high energy state into the low energy state. More signal, but I've got one TR relaxation to measure that signal. So that's the downside of hyperpolarization. One method that I've had the pleasure of working on in York is a parahydrogen-induced polarization technique known as SABRE. This is completely reversible. In short, you hyperpolarize hydrogen by pumping it and cooling it over this catalyst. create your parahydrogen, and then through this IMES catalyst, it will exchange that polarization reversibly with a ligand or your target molecule, and you can then detect that target molecule completely reversible. So in a test tube, I can shake this up, mix it with parahydrogen, and set up my scanner even before I'm injecting. So it does have some advantages over DMP. Again, another advantage of the Saber technique is you've got a much wider range of chemical motifs that you can hyperpolarize. In this example, we hyperpolarize the phenylpyridazine, which is a motif of a lot of anti-cancer agents. You can see we get up to 10% hyperpolarization. And we can start to detect that just in the subcutaneous space. Again, because it's proton, and in terms of imaging, you've got a lot of water in the body, right? It's why MRI works, and we can't saturate out all the water. The shim isn't that great on a person yet to shim out the water and saturate the water completely. So it's very, very noisy to try and do. So DMP still does have the advantage, but I do think that that the range of tracers and drugs that we can polarize with parahydrogen will be important in the future. And I'm going to stop there. There's plenty more I could talk about. I'm hoping somebody's going to ask me a question about phosphorus. Thank you.